Hi, good afternoon. My name is Mike Bushey. I'm a psychiatrist with the IU School of Medicine and IU Health, and I work for the Methodist Addiction Treatment and Recovery Program. And today I'll be talking to you mostly about my work in the Neurobehavioral Therapy Clinic, where we treat patients with chronic pain and conversion disorder as outpatients. I have no disclosures or conflicts of interest with this material. The learning objectives for today, I hope that participants will learn about the complex interplay of disease, dimensions, behavior, and life story in patients with chronic pain. Participants will learn about functional neurological conditions, including functional pain, and participants will learn about the role of cognitive behavioral therapy in treating functional disorders. First, let's talk a little bit about pain. What is it? In my definition, pain is an aversive perception intended to shape behavior. Acute pain provides signals to us to let us know if we've been injured so that we can protect the injured parts of our body and learn about dangerous things to avoid in the future, such as touching a hot stove. Pain includes a perceived location on the body where the injury has occurred, a recognition that this is pain, and a negative emotional experience associated with feeling hurt. Pain is supposed to resolve when healing has occurred. However, there are times when pain continues even after healing, and this is what we call chronic pain. Let's talk a little bit about the anatomy of how pain is transmitted in the body. Pain is first felt at pain receptors out in the skin and other parts of the body. The pain signals are then brought back through nerves, called peripheral nerves, to the central nervous system. They're sent from the spinal cord up to the brain, and the brain is where the pain is perceived. If we look closer at the brain, there's this area called the somatosensory cortex. And if we look really closely at that, scientists have discovered that there is a map of the body, so we can very closely locate where the pain is coming from, depending on which part of the brain receives the signal. So the somatosensory cortex lets us know where the pain is. There are other parts of the brain, such as the insula, that carry some of that other information, such as that negative emotion we talked about that comes with pain. And we know about this from patients who've had injuries to their insula. They can develop a condition called pain asymbolia or pain dissociation, where they can still feel the pain, they know that it's pain, but they no longer experience it as unpleasant. They will no longer withdraw from painful stimuli, such as a hot stove, and they can suffer extreme injuries. Let's talk a little bit about what you might expect if someone comes to you as a doctor reporting pain. If the pain is coming from the pain receptors, we call that nociceptive pain, and there's many conditions where this is the case, such as acute injuries and arthritis. If the pain is coming from damage to the nerves themselves, the peripheral nerves, that's a neuropathic pain, such as what we see with diabetes and viral illnesses many times. Pain can be coming from injury to the central nervous system, such as the spinal cord and the brain, which can occur with conditions like multiple sclerosis. And then there are pain syndromes in which there does not seem to be any injury that we can discover, and those are called functional pain syndromes. And also conversion disorder is what we will sometimes call those conditions. There's also the consideration that someone may report pain even though they're not experiencing pain, which is what we would call malingering. And for the conditions where someone is experiencing pain, if they're experiencing distress with that pain or life disruption, and it's affecting the way that they're thinking, the way that they're behaving, or producing lots of anxiety, we would consider that a somatic symptom disorder. And I just want to point out this is a new diagnosis in the Diagnostic and Statistical Manual, which is a sort of a handbook put out for psychiatrists that replaces the diagnosis of chronic pain disorder that was in previous versions of the DSM. I just want to talk a little bit about conversion disorder and its history. So it has had numerous names throughout history, hysteria being one of the more well-known. Hysteria actually meant the wandering uterus, which was an erroneous theory of why the condition happened. There are examples of conversion disorder that are been shown as far back as 1900 BC. And in the 13th century, women with hysteria or conversion disorder were thought to be witches and were exorcised. Thankfully, physicians have since debunked the erroneous theory about the wandering uterus, and Thomas Sydenham was one of the first to suggest that there might be something going on in the body. Jean-Martin Charcot in the 18th century in Paris believed that there was a condition of the nervous system being disrupted. And Pierre Janet believed that dissociation appears autonomously for neurotic reasons. Probably most famously, and where the term conversion disorder came from, was Sigmund Freud, who argued repressed painful memories could be converted into neurological symptoms. And more recently, we've renamed the disorder functional neurological disorder. I just wanted to provide a few examples of what you may have heard of as mass hysteria to provide a couple of points. First is that conversion disorders can actually become contagious. In these cases that are showing several mass hysteria cases in various places of the world, we can see that many people can be affected at one time. For instance, in the writing tremor epidemic, 20 and then 27 students were affected, and more than 100 people were affected during the Coca-Cola scare in 1999 in Belgium. I also wanted to point out the types of symptoms that we can see, such as dancing, having fits or seizures, trembling, and uncontrolled laughter. Virtually any sensation or motor response can be happening with someone who's having a conversion disorder. So the diagnostic criteria for this disorder include altered motor or sensory function, incompatible with recognized medical conditions. So if someone has a known disorder of the nervous system that could be causing the symptoms, we would give them that diagnosis. It is not explained by another disorder, and there's significant distress or impairment. I just wanted to come back to that point I made about malingering and to make the case that in clinical practice, most of the time we are seeing patients who want help with their symptoms, and so most of the time what we're seeing are patients with either somatic symptom disorders such as chronic pain or conversion disorders where they are unconscious of why the symptoms are happening, but they are having distressing symptoms. And I want to point out that there's not currently objective ways to verify symptoms that people report, such as pain, and that patients seeking treatment should be believed that they're having the symptoms that they're having. We don't routinely recommend polygraph testing to determine if a patient is telling the truth about their symptoms, and frankly, it can be very disheartening to patients when they often are thought to be faking it. I want to talk a little bit about two different cycles that can happen with pain. First, the physical cycle, and then a vicious psychological cycle. So if someone experiences pain, they might begin to avoid activities that cause them pain, which can lead to deconditioning, and that deconditioning can decrease pain initially, but that pain will increase over time as their bodies get weak, and for instance, muscles of the back are no longer supporting the spine, and that leads to more stress on the spine. But the pain that they then experience can lead to further activity avoidance and further deconditioning. On the psychological side, pain can lead to anger, anxiety, fear, and distress, which can lead to worse mood, which can go on to depression, and that depression can then increase the perception of pain. And so cognitive behavioral therapy can be a useful treatment for pain because, on the one hand, the cognitive types of treatments that we use can work on this psychological vicious circle, and behavioral aspects of the treatment, like behavioral activation coupled with physical therapy and exercise, can help with the physical components of chronic pain. I just wanted to provide an example of a thought record that we use in the clinic to work through the cognitive therapy. And what you're seeing here is that what we get patients to do is to really identify emotions and thoughts that are experienced in times of either increased stress or just when bad things happen. And this process of really being able to identify those things and then work through them and find other ways to cope with them can often be very effective in helping manage the symptoms, whether they be chronic pain or conversion disorder symptoms. I also wanted to, for the rest of the talk, really focus in on depression because, as a psychiatrist, it's something that we see a lot of. It's something that plays a very important role in patients with pain, especially patients who are not responding to other treatments. And despite being the most common disorder that we see in psychiatry, it's one that is, can be quite complicated. So I'm going to talk about a very sort of both simple and complex case of Mr. Jones. So Mr. Jones presents with chronic pain. His chart mentions that he has a history of depression and personality disorder. He was in a car accident 10 years ago during which he suffered a broken leg and has had multiple surgeries and bone infections. He's now on disability and has daily persistent pain despite being on increasing doses of oral opioid therapy. He scores a 16 on the PHQ-9 depression scale, which is consistent with moderately severe depression. So the question that I would be encountered with if Mr. Jones came into my office was, why is Mr. Jones depressed? And I approached this using a 4-perspective model to try to figure out the possible things that might be happening with Mr. Jones. And the first perspective we'll look at is the disease perspective. And this is the perspective that we're most familiar with and comfortable with in medicine. This is the perspective that medicine traditionally uses to decide what is happening with a person, what is going on with them, what do they have, and the goal is to find a remedy, ideally a cure, but if not, a treatment that will decrease the symptoms of that disease. And just a reminder that diseases can occur in any part of the body, that a disease is something that happens to somebody because something in their body is not working as it is supposed to, and that in psychiatry we focus on diseases that affect the mind, which is to say the parts of the brain that control emotions, thoughts, and behaviors. So I'm going to introduce a graph that I'll be using in multiple slides here to show mood over time. And so what we're seeing here is a mood of what we would consider an average person. And what we know is that our moods are not the same all the time. There are days and weeks where we'll be in a better mood when things are going well. Maybe you get a promotion or you ace a test. There are times when our mood can get down if you go through a breakup or lose a job. But the point here is that the range of those emotions, they can go up and they can go down, but there is sort of a defined range of quote unquote normal. And that there are times when that can get very disrupted. So the blue line that I just showed here is what we might see in a patient with major depression, which is a disease of the brain in which the mood gets stuck in a very depressed state. And it can remain that way for at least 2 weeks to several months and sometimes even several years. And thankfully, it will often remit or get better or go back to a normal euthymic mood, but that is not always quick, and that's the reason that treatment can be very helpful for these patients to make that happen much faster. I also want to point out bipolar disorder, which can also include these very serious depressive episodes, but also has episodes that we call manic episodes in which the mood can get stuck in a very high state. And so that's just something to be considering if you're seeing a patient who has depressed mood, that they could also potentially have bipolar disorder depending on whether they've had these manic episodes in the past. And in rare instances, they may not have had one yet and may have one in the future. So it's just something for us to be always thinking about. And so just to point out here, the reason we're going down this path is to try to figure out why Mr. Jones has depression. And so one consideration may be that he has a mood disorder like major depression or bipolar disorder that is causing his mood to inappropriately be stuck in a down state. And if that's the case, that we'll need to address that if we want to help him with that depression and with his pain. I'd like to move on to the dimensional perspective, which, unlike the disease perspective, which is looking at what happens when something isn't working the way it's supposed to, the dimensional perspective teaches us that people are different, and sometimes things are working as they should, but just the fact that people are different, that those differences may cause different challenges for people in different situations. And so our goal in working with the dimensional perspective is to guide patients on how to use their dimensions to their advantage. And to give you a very concrete example of dimensions, I'll use height. And this graph here shows on the x-axis, we're looking at height from on the left very short to on the right very tall. And on the y-axis, it's the percentage of people in the population who are at that height. And so, as we can see, most people fall around the average, but there are some individuals who are very tall, and there are some individuals who are very short. And those individuals may encounter difficulties in their lives because the built environment was made mostly for the average height. And so if somebody was coming to your office or you had a friend who had such challenges, they may need to think about that in terms of how they navigate their day. And it may affect employment choices and things of that nature. And I want to point out, just as with the physical dimensions, we vary. Humans also vary in their psychological dimensions, and personality being probably the most famous example of this, and the one that we certainly encounter quite a bit in the mental health space. And personality can be defined in a number of different ways. This is the 5-factor model, which is one of the more common ways to look at this. And what this shows is that there are these 5 different factors: openness to experience, conscientiousness, extroversion, agreeableness, and neuroticism. And people tend to differ in these dimensions, and they tend to differ independently, which is to say someone can be high in openness but low in extroversion, or high in agreeableness and low in conscientiousness, and they seem to be sort of independent. And depending on, just like with height, being on the extremes of these dimensions of personality can make somebody vulnerable to certain situations, and it's helpful for people to be aware of these potential vulnerabilities, which also could be strengths if used in the right way. So for instance, if we look at openness, if someone is very low in openness, they may be very set in their ways, whereas someone who's very high in openness is sort of willing to try anything. In conscientiousness, somebody who's very low tends to be very focused on the present and not giving much consideration to consequences often, whereas somebody who's very high is very focused on how their actions will affect the future. People who are low in extroversion tend to avoid punishment, whereas people who are high in extroversion tend to be directed by rewards and tend to be more vulnerable to rewarding drugs and gambling and things of that nature. In terms of agreeableness, people who are very low can often be a challenge to work with, but tend to be very self-directed, which can be a strength. And in terms of being very high in agreeableness, can be very treatment compliant, but also can be very vulnerable to things like peer pressure. And neuroticism is sort of an unfortunately named personality trait because that term has been used a lot of different ways over the years. But in this context, what it really is referring to is how likely somebody is to experience negative emotions. And so people who are very low in neuroticism, you can think of James Bond or someone who's almost robotic, like Spock in Star Trek, of having very limited emotional range, whereas someone who's very high in neuroticism may experience very intense negative emotions. And if we dive deeper into the facets of neuroticism, we see that the emotions in particular include things like depression, anxiety, hostility, and impulsiveness, vulnerability, and self-consciousness. And so going back to our thoughts about mood and depression, if we were to take somebody who is sort of average in neuroticism, they might look like that person that we showed originally on this mood graph. Whereas somebody who's very high in neuroticism, meaning that they experience very intense emotions like depression, anxiety, and anger, their emotions might be more intense and might change more rapidly. And so that could lead to them having these very intense negative emotions, which would be experienced by them and would look to a clinician like depression. And this is different than what we saw with major depression or bipolar disorder, where those depressive episodes are prolonged, lasting weeks to months. These can last minutes to hours, but can be very, very intense. Let's move on to the behavioral perspective. This is looking at what a person does. And with behaviors, the therapeutic goal is to try to interrupt the behavior and try to break patterns. There are several different types of behaviors. I want to point out two very important ones for understanding psychiatric illness and chronic pain. The first is learned behavior. This is probably what we're most familiar with and comfortable with and think about the most in day-to-day life. And that is that we recognize that behaviors have consequences. And if those consequences are pleasurable, such as the delicious taste of sugar cream pie, then that might reinforce that behavior. And so somebody might experience that pie and decide that the next time they see it on the menu, they really want to order that again. However, negative experiences, such as touching a hot stove, would bring with them the idea that that was a very negative experience, and I would prefer not to do that again. And so this is sort of the way that our brain was set up to help us try to learn to do things that would be beneficial for us and to try to avoid things that would be potentially very dangerous for us. But there's another kind of behavior that doesn't require any learning, which is called a driven behavior. And these are things that we do innately from the time we're born. Things like eating, drinking, sleeping. These are things that our body just needs. And so that behavior is driven. We then act on that drive. And when the drive is satisfied, we get a reprieve from that drive until it gets activated again. And what this looks like with eating is that if you've gone some time without eating, you could get hungry, and that hunger will build over time, and eventually you will eat. And if you are able to get sufficient enough food, then that hunger will go away, and then sometime later it'll come back. And that's sort of the cycle of a driven behavior. And what's interesting with things like opioids and other addictive substances is that they start out like a learned behavior. So someone is not born with an innate drive to use opioids. However, if they're exposed to opioids and then experience a positive consequence like euphoria, and this seems to be something that is determined by our genes. It is probably related to the way our brains are constructed, and different people are more or less likely to have this experience. But if someone does have this experience, it will make them much more likely to want to use opioids and to develop an addiction or an opioid use disorder. On the other hand, there are people who will use opioids and have a very negative experience. Some people can experience extreme nausea, and this may lead them to never want to try opioids again. But for those who do have that euphoric response and begin taking opioids consistently, over time, they can develop a drive to use those opioids. And in that case, their body has become what we call dependent on it. So they will actually develop withdrawal symptoms if they don't have opioids in their body, and then they will need to use opioids to feel better and make that withdrawal go away. And then once that effect has worn off sometime later, they will be back into the cycle. And this is something that we really need to understand when we're trying to help somebody who has developed an opioid use disorder to no longer be affected and driven to use them, and why we need to help people break this cycle. I also want to point out, since we're really focused on depression here, is that with opioid use disorder, people can, over time, actually develop pretty significant negative moods during those withdrawal states. And what we're seeing here is that euphoria that comes with that first use of opioids is often very difficult to achieve that again. And some refer to this as sort of chasing the dragon. And what actually happens is over time, when dependence develops, patients are no longer in a situation where they are actually feeling good. Really, they're in a cycle of going between feeling really bad and then needing that opioid to just feel sort of normal. And that can cause some significant depression. And it's not just opioids, we see this with other substances as well. But those sort of withdrawal states, often depression is a significant component of it. Let's switch gears and talk about the life story perspective. And the life story perspective, we think about what a person encounters. And for this condition, of life, what we really are trying to do for providers is help people re-script what has happened and to heal if they've suffered any significant emotional injuries related to something that's happened in their lives. And I want to make an important point about this, which is that when somebody experiences trauma, say a car accident, they may experience both physical and psychological damage and injury, such as a broken bone for a physical condition, or if the injury happens in the sort of thought, emotion, and behavior parts of the brain, we would, term that psychological injury. But just because someone suffers an injury doesn't guarantee that they will have long-term negative outcomes. People do have broken bones that heal well, and people can get over the initial nightmares of depression and panic attacks that can sometimes come after things like car accidents. But it's also important to recognize that sometimes people don't heal well. Sometimes broken bones don't heal as they're supposed to, and people can have recurrent infections and need to have surgeries and need to have screws placed to get proper alignment. And sometimes people continue to have symptoms like nightmares and depression and panic attacks after a traumatic event and develop post-traumatic stress disorder. And my point here is that I've often, in talking with colleagues about patients with chronic pain, there's often a search for trauma, and I want to point out that trauma is very important when it leads to lingering symptoms and when there is something continuing to happen that's related to that trauma. But the focus, I believe, is best placed on the symptoms and what to do now and how to help relieve the symptoms. And sometimes that requires going back and working through the trauma, but not always. And I think that's an important point in talking about life story. I also want to point out that other than these really significant traumas, there are other life story considerations that can contribute to chronic pain. For instance, some families have a scenario set up where illness is something that is rewarded, or somebody may slip into a lifestyle where being on disability or being ill is accepted. They may become, unfortunately, reliant on disability income, which can reinforce chronic pain and illness condition. Some people have a lack of role modeling of meaningful sacrifice and acceptance of discomfort, which can lead to significant distress when faced with conditions like chronic pain. There's also the loss of identity, resources, support systems that can happen when someone becomes chronically disabled or suffers from daily pain or other conditions. And then there's this condition called demoralization, which results from a loss of mastery or a loss of control, or someone feeling like they no longer have control over their lives. And demoralization can be a really significant consideration because it can lead to a depressed mood and can lead to people giving up sometimes. And so getting back to our mood chart here, if we look at an average person going through life and they experience significant loss, they could become overwhelmed and demoralized by that, and that could lead to them being depressed. And so getting back to Mr. Jones, if we ask, why is Mr. Jones depressed, we would have to really consider all the possibilities. Maybe he has major depressive disorder or bipolar disorder, or he has a temperament that just leads to him experiencing lots of depression. Maybe he has developed an opioid use disorder from his daily opioid prescriptions and is experiencing significant negative withdrawal during the day. Maybe he's demoralized because he's had a lot of losses and he feels like he has no control over his life anymore. And my point with this slide is that it could be all of these. It could be some of these, but really trying to think through that it doesn't need to be all of these either. And I think that's what we really need to think about when we're talking about patient-centered care, is that each patient is an individual and can have lots of different things going on. And to me, the reason that this is important to think about is because the different conditions someone might be facing will guide our treatment. Like I said from the beginning, these different perspectives have different treatment goals. So if someone has a mood disorder, like major depression or bipolar disorder, the goal is to treat that and to try to get them into a place where their mood isn't wildly unstable. And we're very fortunate that we have effective treatments for these conditions. We have medications such as antidepressants. There are psychotherapies like CBT can actually be quite effective for treating depression. And in very extreme cases, patients who have symptoms that do not respond to medications and do not respond to psychotherapy, and if someone is very severely depressed, perhaps suicidally depressed, we are very fortunate that we have electroconvulsive therapy, which, while it has been sort of villainized by the film industry and does have, as with psychiatry in general, there is a history of things that would have been nice to have gone better. At this point, ECT is a treatment that is 90% effective at getting folks better from a severe depression, and is something that we are very fortunate to have if we need it. It's a procedure. It requires anesthesia, so it's not something that we use lightly, but it is nice to have if someone is experiencing very severe symptoms that are not getting better with other treatments. But with the other perspectives, like somebody with high neuroticism who experiences a lot of depression, a lot of anxiety, and the point here is that is not likely to just get better with medications, because that's part of the way that they're built. And one of the things that I always make sure to talk to patients about is that I don't see these as strengths or weaknesses so much as potentials. And so somebody who's very high in neuroticism, it can be very difficult, and they can experience a lot of depression and anxiety, and that can lead to the need often for mental health treatment. But it also provides a lot of strength in terms of being empathetic. I mean, there's somebody who can understand what other people are going through, and that really translates. And so often, the actors and actresses who are very good at their craft can be high in this trait. So it's something that can be, if learned to be used, can actually become an asset, but does make them vulnerable to depression. With an opioid use disorder, we need to interrupt that behavior, and that often includes using medications that can help break or satisfy that drive. And so thankfully we have medications like methadone and like buprenorphine that can break that cycle of dependence that drives people to have to use other opioids, and so that they can not be in a condition where their lives are driven by the need for opioids. And with demoralization, again, psychotherapy is sort of the mainstay of treatment for that, and it's about getting patients to see where they've come and get them to build hope back that things can get better, and to help them forge a path to that better life. And so that's really what we focus on when someone's life circumstances and their feelings about those life circumstances are sort of really important to what's going on. So in conclusion, we talked about the fact that when a brain isn't functioning properly, and we talked about many different reasons that might be the case, that can lead to persistent pain and functional neurological symptoms. We talked about the fact that these symptoms are usually very real and can be very distressing for patients. We talked about that if these symptoms are very real for patients, that they would make them go away if they knew how, and that's why they're coming in for treatment. So it's very important for us as clinicians to listen to patients and to try to work with them to find a path forward. Depression makes everything worse. Depression really is a huge driver for chronic pain. And I should say, I've focused on depression. It's an important consideration. When it is happening, it is really important to address, and as we talked about in this presentation, it can be complex as to what's causing it. But it's not always the case, so I don't want to make it sound as if every patient with chronic pain is depressed and needs treatment for that. So it really is important to assess patients and to figure out what is happening. And when depression is present, there's lots of things that can be causing it, and so the treatment is complex sometimes. We talked about that personality traits can interact with somatic symptoms like pain. We didn't get too much into how this occurs. We talked about that some people are more prone to experience negative emotions, but one of the reasons that leads to a more intense experience of pain is that they can lead to a condition called catastrophizing, where someone can think things like, this pain is never going to get better, or I'll never be able to do the things I wanted to do again. And those types of thought patterns are more common in patients that experience intense depression and anxiety, and so that's often the focus of things like cognitive behavioral therapy. We talked about conditioned drive that can occur when folks are using opioids on a daily basis, and how that can really reinforce pain symptoms and behaviors. We talked about life story narratives that can either reinforce disability or protect against it. And we talked a little bit about how CBT can be very helpful for managing the thoughts, anxieties, and behaviors associated with chronic pain and functional neurological conditions. This concludes my talk. I really appreciate your time, and I look forward to answering any questions you might have.